Every single day, people walk into doctors' offices after months, sometimes years, of real symptoms. Fatigue that sleep doesn't fix, mood changes that don't make sense, a loss of vitality, mental sharpness, or libido that feels like something fundamental has shifted. They describe everything. They wait for answers, and they leave with either no testing at all or a single basic test that tells them almost nothing about what's actually going on. This is one of the most common and most correctable failures in routine healthcare. And it happens because most people don't know what to ask for, don't know how to advocate for themselves, and can't interpret their results even when they do get them. This video fixes all three of those problems. We're going through everything: the symptoms that signal it's time to get tested, the specific tests that make up a genuinely comprehensive hormone evaluation for both men and women, how to prepare so your results are actually accurate, how to read and interpret those results with real understanding, the exact language to use with your doctor, what to do when results come back abnormal, and when to ask for a specialist referral. By the end of this, you'll walk into your next appointment more prepared than the vast majority of people who sit in that same chair. Let's start with symptoms, because this is where most people's journey either begins productively or gets completely stuck. Hormonal imbalances produce symptoms that are real and often significant, but also nonspecific. They overlap with other conditions. They get attributed to stress, aging, or lifestyle. And that's exactly why they're so often dismissed. In men, the symptoms most commonly linked to hormonal imbalance, particularly low testosterone, include persistent fatigue that isn't explained by poor sleep, reduced libido, or changes in sexual function, loss of muscle mass despite consistent training, increased body fat especially around the abdomen, mood changes like irritability, low motivation, or depression-like symptoms, reduced mental sharpness, sleep disturbances, and decreased physical stamina and recovery. These symptoms rarely appear alone. When several show up together without another clear explanation, hormonal evaluation is warranted. In women, hormonal symptoms are often tied to cycle changes, irregular, painful, or absent periods, severe premenstrual symptoms, difficulty conceiving, persistent jawline acne, unwanted hair growth, hair thinning, significant mood fluctuations, brain fog, fatigue, sleep disruption, and reduced libido. Then there are the symptoms of perimenopause, hot flashes, night sweats, vaginal dryness, and disrupted sleep. Thyroid dysfunction, which affects women far more than men, adds its own layer. Unexplained weight changes, fatigue, cold intolerance, hair loss, mood changes, and digestive issues. For both men and women, multiple symptoms from these lists, without another identified cause, is a reasonable basis for requesting a comprehensive hormone evaluation. Here's a simple but powerful tip. Before your appointment, write down your specific symptoms, how long you've had them, and how they're affecting your daily life. Bring that list with you. It strengthens your case for testing and helps your doctor see the full clinical picture, not just isolated complaints. Now, let's get into what a genuinely comprehensive hormone evaluation actually includes, because this is where most routine testing falls critically short. A complete hormone assessment is not a single test. It's a panel of related measurements that together reveal how multiple hormonal systems are functioning and how they're interacting with each other. Let's start with men. The first test most doctors order is total testosterone. This measures the total amount of testosterone in the bloodstream, both the portion bound to proteins and the free, unbound portion. It's a necessary starting point. But here's the problem: total testosterone alone is frequently not enough. That's where free testosterone comes in. Free testosterone measures only the portion that isn't bound to proteins, the biologically active testosterone that your tissues can actually use. It's entirely possible to have a total testosterone that looks normal on paper, while free testosterone is meaningfully low. For understanding your actual hormonal status at the tissue level, free testosterone is arguably more clinically relevant. And here's why that happens. Sex hormone binding globulin, or SHBG. SHBG is the protein that binds testosterone and estrogen in the bloodstream. regulating how much is free and active. When SHBG is elevated, it locks up more testosterone, leaving less available to your body, even when total levels appear fine. SHBG is influenced by thyroid function, liver health, and body weight. Without measuring it, you're missing a critical piece of the puzzle. Next, luteinizing hormone and follicle-stimulating hormone, known as LH and FSH. These are pituitary hormones that signal the testes to produce testosterone and sperm. Testing these alongside testosterone tells you whether a testosterone abnormality is originating in the testes themselves or in the pituitary regulation of testicular function. That distinction matters enormously for diagnosis and treatment. Now here's one that's almost always left off basic panels: estradiol. Yes, men need estrogen too. Estradiol supports bone health, cardiovascular health, cognitive function, and libido in men. When estradiol is too high relative to testosterone, often due to increased aromatase activity associated with excess body fat, it produces symptoms including reduced libido and mood changes. When it's too low, it increases risk of bone loss, joint pain, and cardiovascular issues. Measuring estradiol in men is essential, and it's routinely skipped. Thyroid-stimulating hormone, TSH, is the standard initial screening test for thyroid function. Because thyroid dysfunction affects energy, mood, body composition, and interacts directly with sex hormone systems, it belongs in every comprehensive hormonal evaluation. But TSH alone isn't enough for anyone with thyroid symptoms. A complete thyroid panel should also include free T4 and free T3, the active thyroid hormones, plus thyroid antibodies, specifically thyroid peroxidase antibodies. These identify whether autoimmune thyroid disease is the underlying cause, which changes everything about how it's managed. DHEAS, dehydroepiandrosterone sulfate, is an adrenal hormone that serves as a precursor to both testosterone and estrogen. It reflects adrenal function and declines significantly with age. It's relevant to energy, hormonal balance, and overall vitality, and worth including in any comprehensive panel. Cortisol, the primary stress hormone, has an inverse relationship with testosterone and affects multiple hormonal pathways. A morning cortisol measurement gives a basic snapshot of adrenal output. For a more complete picture, a 4-point salivary or urine cortisol assessment across the day reveals the full cortisol rhythm, not just one moment in time. Prolactin is a pituitary hormone that, when elevated in men, suppresses testosterone production and causes sexual dysfunction. When testosterone comes back low, checking prolactin is an important part of investigating why. Rounding out a comprehensive male panel, fasting glucose and insulin assess insulin sensitivity, which interacts extensively with sex hormone systems. And vitamin D, which functions as a hormone in the body, should always be measured given how prevalent deficiency is and how directly it affects hormonal health. Now, let's talk about women. There's meaningful overlap with the male panel, but female hormonal evaluation includes additional components specific to reproductive hormones and their natural cycling. Estradiol in premenopausal women varies significantly across the menstrual cycle, so timing matters. Testing on day 3 of the cycle gives a baseline follicular phase measurement. Testing in the mid-luteal phase, approximately 7 days after ovulation, provides information about peak luteal estrogen and progesterone together. Progesterone is produced primarily in the second half of the cycle after ovulation. Mid-luteal progesterone testing is essential for confirming whether ovulation actually occurred and whether the luteal phase is producing adequate progesterone. Low progesterone is associated with premenstrual symptoms, irregular cycles, difficulty conceiving, and a range of hormonal imbalance symptoms that are consistently underinvestigated. LH and FSH in women provide information about pituitary regulation of the ovarian cycle. Elevated FSH combined with low estradiol suggests reduced ovarian reserve or approaching menopause. And the LH to FSH ratio is specifically relevant in assessing polycystic ovary syndrome. Total and free testosterone matter for women too, particularly for those with post-androgen excess symptoms like acne and unwanted hair growth, or symptoms of low libido and reduced energy. SHBG is equally important in women for understanding the availability of both testosterone and estrogen. Anti-Mullerian hormone, AMH, is a marker of ovarian reserve relevant for women with fertility concerns or those wanting to understand their reproductive timeline as they approach their later reproductive years. The full thyroid panel is particularly critical for women given the significantly higher prevalence of thyroid dysfunction compared to men. DHEAS, cortisol, prolactin, fasting insulin, and glucose, vitamin D, and a complete metabolic panel round out a comprehensive female hormonal evaluation. This is what a real, complete picture looks like. Not a single test, not two markers checked in isolation. A full panel, interpreted together, that actually tells you something meaningful. Now, let's talk about something that significantly affects the accuracy of your results, but that most people are never told about. How to prepare for hormone testing, because getting the right tests ordered is only half the battle. If your results aren't accurate, the entire evaluation is compromised. Timing is one of the most critical preparation factors, particularly for sex hormones. Testosterone in men is highest in the morning, typically peaking between 7 and 10 a.m. and declines throughout the day. Standard practice is to test testosterone before 10 a.m. for the most clinically meaningful and reproducible results. Afternoon or evening testing can produce results that appear artificially low, potentially leading to a misdiagnosis or an inaccurate picture of your true hormonal status. For women, timing relative to the menstrual cycle is equally critical. Day 3 testing is standard for baseline FSH, LH, and estradiol. Mid-luteal testing, approximately 7 days after ovulation, is the appropriate time for progesterone. Testing at the wrong phase of the cycle can produce results that are difficult to interpret or outright misleading. When scheduling your testing, communicate exactly where you are in your cycle so testing can be timed appropriately. Fasting status matters for glucose and insulin testing, and some practitioners prefer fasted hormone testing across the board to reduce variability. Confirm with your doctor whether fasting is recommended for your specific panel before your appointment. Sleep quality in the nights before testing can affect hormone levels, particularly testosterone in men, which is significantly influenced by sleep. Testing following a period of serious sleep deprivation may not accurately reflect your typical hormonal status. If you've had several rough nights, it's worth noting that when your results come back, acute illness, intense recent exercise, significant psychological stress, and alcohol consumption in the days before testing can all shift hormone levels. Ideally, avoid these in the days leading up to your blood draw for the most representative results. And here's one that catches a lot of people off guard. Biotin, found in many supplements and hair, skin, and nail products, can interfere with multiple laboratory hormone assays and produce inaccurate results. It should generally be stopped for at least 3 days before hormone testing. Discuss all current medications and supplements with your doctor before your panel is ordered. Preparation isn't complicated, but skipping it can undermine everything. A few simple steps ensure that the results you get actually reflect what's happening in your body. Now, let's get into one of the most important and most misunderstood aspects of this entire process: how to actually read and interpret your results. Specifically, the critical difference between normal reference ranges and optimal ranges. This distinction is at the heart of countless frustrating medical appointments, and understanding it changes everything. When you receive hormone test results, each value comes with a reference range. These ranges represent the statistical distribution of values found in a reference population, typically defined as the middle 95% of values measured in a presumably healthy population. A result within this interval is considered normal. A result outside it gets flagged as abnormal. Here's the problem. These ranges are broad. They're often derived from populations that include people with suboptimal health. and they define the absence of a flagged abnormality, not the presence of optimal function. A man with testosterone at the very bottom of the normal range is technically not flagged as low, but he may be experiencing every symptom of low testosterone and may feel meaningfully better with levels in the upper portion of the range. His result isn't abnormal, but it isn't optimal either. This is why so many people are told their hormones are normal, while they continue experiencing real symptoms that aren't being addressed. The labs aren't flagged. The conversation ends, and nothing changes. Understanding the difference between normal and optimal allows you to have a far more productive conversation with your provider. Instead of simply asking whether your results are normal, ask where specifically within the range your results fall. Ask whether your symptoms could be connected to levels that, while technically within reference, sit at the lower end of the spectrum. Let's walk through the key markers and what their results actually mean in practical terms. For total testosterone in men, conventional reference ranges typically span from approximately 300 to 1,000 nanograms per deciliter. A result of 305 is technically within range, but it's sitting at the absolute floor. Many men with results in the lower portion of this range experience significant symptoms that improve with optimization. A result of 750 in the upper portion is associated in research with notably better energy, vitality, libido, and body composition outcomes. Where you fall within that range matters, not just whether you cleared the cutoff. Free testosterone reference ranges span a similarly wide spectrum. Values at the lower end may be clinically significant even without being flagged. And when SHBG is elevated, free testosterone can be low even when total testosterone appears adequate, which is exactly why measuring both provides a meaningfully more complete picture. For estradiol in men, elevated levels, typically above approximately 40 to 50 picograms per milliliter, are associated with reduced libido, mood changes, and symptoms of androgen to estrogen imbalance. Very low estradiol carries its own risks: bone loss, joint pain, and cardiovascular concerns. The goal is appropriate balance, not simply landing somewhere within a broad range. 4. TSH. Conventional thresholds flag abnormality outside approximately 0.4 to 4.0 millunits per liter. But many experienced practitioners, including Dr. Eva Danielle, consider optimal TSH to sit more narrowly between approximately 1.0 and 2.5 millunits per liter for most people. Someone with a TSH of 3.8, technically normal but toward the upper end, who also has hypothyroid symptoms and positive thyroid antibodies, may have a clinical picture that warrants further evaluation rather than simple reassurance. Free T3 and free T4 results that fall in the lower portion of their reference ranges, even without being flagged, may contribute to symptoms in people who are sensitive to lower thyroid hormone levels. Again, where within the range matters, interpreted in context of your full symptom picture. For women, progesterone measured in the mid-luteal phase should typically be above approximately 10 nanograms per milliliter to confirm adequate ovulation, with many practitioners preferring levels above 15 for optimal luteal phase function. Results below these thresholds suggest either anovulation or a compromised luteal phase, which may explain premenstrual symptoms, cycle irregularities, or difficulty conceiving. Estradiol in premenopausal women varies enormously across the cycle and must always be interpreted in context of when testing occurred. Postmenopausal estradiol below approximately 25 to 30 picograms per milliliter is associated with bone loss and the symptom burden of estrogen deficiency. Vitamin D results should ideally fall between approximately 40 and 60 nanograms per milliliter for optimal hormonal health benefit, not simply above the deficiency threshold of 20 nanograms per milliliter that most labs use as their lower cutoff. Normal is not the same as optimal, and for hormonal health, that distinction is everything. Now, let's talk about how to actually have this conversation with your doctor, because having the knowledge is only valuable if you can translate it into a productive medical interaction. The foundational principle is this: approach the conversation as a collaborative, clinical discussion, not a confrontation, not a demand. You are not trying to override your doctor's judgment. You are trying to ensure your clinical picture is fully assessed with the testing your symptoms actually warrant. Before your appointment, write down your symptoms in specific, concrete terms, not simply fatigue, but persistent fatigue for the past 8 months that is present even after 7 to 8 hours of sleep and is affecting my ability to perform at work. Not simply low mood, but reduced motivation, irritability, and a sense of emotional flatness that is different from my baseline and has been present for 6 months. Specificity matters. It demonstrates that these are real, sustained, impactful symptoms, not passing concerns. And it helps your doctor build a complete clinical picture rather than responding to vague complaints. Bring a written list of the specific tests you want to request. Be prepared to explain briefly why each one is relevant to your symptoms. You don't need to demand anything. You simply need to ask clearly and explain your reasoning. Here's language you can use directly. I've been experiencing these symptoms for this period of time, and they're significantly affecting my quality of life. I'd like to request a comprehensive hormone panel that includes not just total testosterone, but also free testosterone, SHBG, LH, FSH, estradiol, a full thyroid panel including TSH, free T3, free T4, and thyroid antibodies, DHEAS, a morning cortisol, prolactin, fasting insulin, and glucose and vitamin D. I want to make sure we're getting a complete picture rather than just 1 or 2 isolated markers. Most doctors who hear a patient present this clearly and specifically will engage productively. You're not asking for anything unreasonable. You're asking for thoroughness. If there's pushback about the breadth of testing, ask specifically which tests are most appropriate to start with given your symptoms. Discuss a staged approach where initial results inform whether further testing is needed. This is a reasonable middle ground that keeps the conversation moving forward. If you're a woman requesting cycle-appropriate testing, be specific about where you are in your cycle. Ask directly about timing for progesterone testing in the mid-luteal phase rather than just at any random point in the month. This one detail makes a significant difference in whether your progesterone results are actually interpretable. Now, what if your doctor is dismissive? If your symptoms are minimized without adequate explanation, or if comprehensive testing is refused without a clear clinical reason, you have options. You can request a second opinion. You can ask for a specialist referral. You can seek care from a different provider entirely. Your symptoms are real. Your request for investigation is reasonable. You deserve a provider who takes both seriously. Advocating for yourself in this situation is not being difficult. It is being responsible about your own health. Now, let's address what to do when your results come back abnormal, because this is where many people hit another wall. The first thing to understand, a single abnormal result is the beginning of an evaluation, not the end of one. An isolated low testosterone, an elevated TSH, and abnormal estradiol. All of these findings require context and often additional investigation before a diagnosis is confirmed and a treatment plan is developed. Don't let anyone treat a single number as the complete story. When results come back abnormal, ask your doctor these specific questions. What does this result mean specifically for my health? What additional testing is needed to understand the cause of this abnormality? What are the treatment options, and what is the evidence behind each one? What are the risks and benefits of treatment compared to monitoring without treatment at this stage? And what timeline for follow-up testing is appropriate? For testosterone abnormalities in men, the investigation typically involves determining whether the issue is primary, meaning it originates in the testes, or secondary, meaning it originates in the pituitary or hypothalamus. LH and FSH results are what make that distinction. This matters because it points toward different causes and entirely different treatment approaches. Before testosterone replacement therapy is considered, other potentially treatable causes should be evaluated first. Thyroid dysfunction, sleep apnea, significant obesity, medication side effects, All of these can suppress testosterone and are worth addressing before moving to hormone replacement. 4. Thyroid abnormalities. The presence of thyroid antibodies significantly changes the clinical picture and treatment approach. Confirmed hypothyroidism generally warrants thyroid hormone replacement. Subclinical hypothyroidism, where TSH is mildly elevated but free T4 remains within range, requires individualized judgment based on symptom burden, antibody status, and other clinical factors. It's not a one-size-fits-all decision. For women with hormonal abnormalities, the specific findings guide what comes next. Elevated androgens and LH to FSH ratio abnormalities alongside irregular cycles suggest investigation for PCOS. Low mid-luteal progesterone may warrant investigation of ovulatory function. Elevated FSH combined with low estradiol in a woman in her late 30s or 40s suggests diminished ovarian reserve or early perimenopause. These findings all warrant thoughtful clinical evaluation, not simply treating an isolated number, but understanding what that number is telling you about the underlying system. Now, let's talk about when and how to ask for a specialist referral, because primary care physicians are an essential starting point, but they have real limits in the depth of their hormonal expertise. Knowing when to go further is part of advocating effectively for yourself. An endocrinologist specializes in hormonal and metabolic conditions. This is the appropriate specialist for complex thyroid disorders, adrenal conditions, pituitary abnormalities, diabetes, and complex hormonal imbalances that aren't straightforward to manage in primary care. If your primary care physician identifies a hormonal abnormality that requires specialized investigation, a referral to endocrinology is appropriate and you are entitled to request one. A reproductive endocrinologist specializes in hormonal aspects of reproductive health and fertility. This is the right specialist for complex PCOS cases, unexplained infertility, recurrent pregnancy loss, and complex perimenopause management. A urologist with expertise in men's health, or a dedicated men's health specialist, is appropriate for testosterone abnormalities, particularly when testosterone replacement therapy is being considered and requires careful evaluation and monitoring. A gynecologist with a focus on hormonal health or menopause medicine is appropriate for complex perimenopause and menopause management, including thorough discussions of hormone replacement therapy, its risks, and its benefits in your specific individual case. And if your primary care physician simply isn't familiar with the breadth of hormone testing we've discussed, or if you consistently feel your concerns aren't being adequately addressed, seeking care from a provider with specific expertise in hormonal health is a reasonable and proactive step. This includes functional medicine physicians, integrative medicine practitioners, and the specialists listed above. Dr. Eva Danielle emphasizes something important here. Finding a provider who genuinely listens, who orders comprehensive testing, and who interprets results with nuance rather than simply checking a box is not a luxury. It's the standard of care you deserve. Let's close with the bigger picture, the one that ties everything in this video together. Your hormonal health is one of the most important dimensions of your overall well-being. It influences your energy, your mood, your sleep, your cognitive function, your body composition, your sexual health, your cardiovascular health, your bone density, and your quality of life in ways that are both profound and concrete. And the only way to know with certainty what your hormonal health actually looks like is to measure it with appropriate, comprehensive testing, interpreted with real understanding rather than simply checked against broad reference ranges. Most people never get that, not because the testing doesn't exist, not because the science isn't clear, but because they didn't know what to ask for and nobody told them. You now know. Let's do a complete recap, because this framework deserves to be seen as a whole. Step 1 is recognizing the symptoms that warrant investigation. Persistent fatigue, mood changes, reduced libido, loss of muscle, brain fog, cycle irregularities, perimenopausal symptoms, unexplained weight changes. When multiple symptoms from these categories appear together without another clear cause, that's your signal. Don't wait years. Make the appointment. Step 2 is knowing exactly what to request. For men, total testosterone, free testosterone, SHBG, LH, FSH, estradiol, full thyroid panel including TSH, free T3, free T4 and thyroid antibodies, DHEAS, morning cortisol, prolactin, fasting insulin and glucose and vitamin D. For women, estradiol and progesterone time to the cycle, LH, FSH, total and free testosterone, SHBG, AMH when relevant, the complete thyroid panel, DHEAS, cortisol, prolactin, fasting insulin and glucose and vitamin D. A complete picture, not 2 markers checked in isolation. Step 3 is preparing correctly. Test testosterone before 10 a.m. Time, female hormone, testing to the appropriate phase of your cycle. Fast when recommended. Avoid intense exercise, alcohol, and significant stress in the days before testing. Stop biotin supplements at least 3 days prior. These steps protect the accuracy of everything that follows. Step 4 is reading your results with real understanding. Normal is not the same as optimal. Where you fall within a reference range matters, not just whether you cleared the cutoff. A result at the bottom of normal with a full symptom picture is not the same as a result in the upper portion of normal. Ask your doctor where specifically your results fall. Ask whether your symptoms could be connected to levels that are within range, but suboptimal. Push past the checkbox mentality. Step 5 is having the right conversation. Come prepared with a written symptom list, specific, concrete, and time-stamped. Bring your test requests in writing. Use collaborative language that invites clinical partnership rather than confrontation. If you face dismissal without adequate justification, seek a second opinion, request a referral, or find a provider who will take your concerns seriously. Step 6 is knowing what to do when results are abnormal. A single abnormal finding opens an investigation. It doesn't close one. Ask what the result means, what caused it, what additional testing is needed, and what treatment options exist with their evidence base and risk-benefit profile. For testosterone abnormalities in men, determine primary versus secondary before considering replacement. For thyroid findings, factor in antibody status before deciding on treatment. For women, let the specific pattern of findings guide the clinical next steps rather than treating isolated numbers. Step 7 is knowing when to escalate to a specialist. Endocrinology for complex thyroid, adrenal, and pituitary conditions. Reproductive endocrinology for fertility and complex PCOS. Men's health specialists or urologists for testosterone evaluation and replacement therapy. Gynecologists specializing in hormonal health for perimenopause and menopause management. If your primary care physician has reached the limits of their hormonal expertise, a specialist referral is not an escalation. It's the appropriate next step. Now, here's what I want you to actually do with this information. If you've been experiencing symptoms that fit the patterns described in this video, don't put this off. Schedule the appointment this week. Write your symptom list tonight. Use the specific language from this video. Walk in prepared. If you've already had hormone testing but received only basic results with minimal explanation, go back. Ask for the complete panel. Ask where your results fall within the ranges, not just whether they're flagged. Ask the follow-up questions that weren't asked the first time. If you've been dismissed or told everything is normal while your symptoms persist, seek a second opinion. You are not overreacting. You are not being difficult. You are doing exactly what an informed, responsible person does when their health isn't being adequately addressed. And if you're supporting someone else, a partner, a parent, a friend, who has been struggling with unexplained symptoms without answers, share this video with them. The knowledge here is genuinely useful. And sometimes the most valuable thing we can do for someone is hand them the information that finally makes the path forward clear. As Dr. Eva Danielle consistently reminds her patients, you are the most important advocate for your own health, not because the medical system is adversarial, but because no one has more at stake in your well-being than you do. Showing up informed, prepared, and clear about what you need is not pushing back against your healthcare provider. It is the foundation of genuinely productive healthcare. You now have the framework, the specific tests, the preparation steps, the interpretation tools, the language, the follow-up questions, and the roadmap for when and how to escalate. Everything you need to advocate for comprehensive, meaningful hormonal evaluation starts with the conversation you are now fully prepared to have. Your hormonal health deserves that level of attention, and so do you. If this video prepared you for an appointment you've been putting off, or gave you the language to finally have a productive conversation about your hormonal health, please share it with someone who needs it. Subscribe for more evidence-based health content, and drop a comment below telling me which part of this process has been most challenging for you, whether that's getting the right tests ordered, understanding your results, or knowing what to do next. This community and this conversation genuinely matter,